Good evening and a very warm welcome to this first NB Medical Clinic of 2024. It is absolutely fab to have so many people join us this evening. It's brilliant to have such large numbers on a very cold January evening. And this evening's clinic is super special because it is brought to you not just by NB Medical, but in partnership with Cancer Research UK as well. So a quick round of introductions before we get started. If you are an NB Medical aficionado, I'm sure you've seen my mug before, but my name is Kate Digby and I am a GP partner at a very lovely practice in Cirencester in the South Cotswolds. I've got a bit of a portfolio spread to my week, so I'm a trainer in the practice, I'm the clinical director for our local PCN, and on Wednesdays I work as a TPD, training up the future generation of GPs. And I've been working with NB Medical now for many, many years, writing material and presenting courses. So I am very excited to be with you this evening. But the good news is that I am not here alone this evening because I have with me an absolute expert in the field that we are talking about this evening, which is bowel cancer. So without further ado, and in true cheesy TV style, let me hand over and introduce you to Katie Elliott.
Thanks, Kate, and that's a lot to live up to. Hello, everybody. My name's Katie Elliott. I'm a GP in North Shields, up in the northeast of England. I'm also cancer research, part of a network of GPs across the country that look at cancer pathways, working with our cancer alliances. And the other part of my job is as a clinical director for the Northern Cancer Alliance with a primary care perspective. And I'm also a GP appraiser as well, so I'm fortunate to get a good perspective across the breadth of general practice. And we are also accompanied by our esteemed colleague Will Duffin as well, so I'll hand over to Will.
You are indeed, Katie. Yeah, good evening, Katie. Good evening, Kate. And good evening to you at home as well. What a great evening, a great topic this is. I mean, let's face it, fit testing, bowel cancer diagnosis, this seeds so many seeds of confusion for all of us. And I'm not alone. I think here I see patients as a jobbing GP in Exeter with dubious symptoms of possible bowel cancer, and I'm always thinking, could a fit test really add value here? And it's been huge changes in this area, so it's a really exciting time to be looking at this topic. We've got so much expertise here in the form of Kate, MB Cancer Lead, and also Katie from CRUK. I'm here really to steward the fun on the Q&A, so if you haven't done so already, please find the Q&A box at the bottom of the console, say hello. As we go through this session, I'd be really grateful to hear your thoughts, comments, questions on the material. How do you find it implementing some of these guidance? What do you think about changes to the screening in different parts of the UK? And any insights that you found helpful that would be useful for us to cascade out to the rest of the group. So I'm looking forward to interacting with all of you this evening. In the meantime, Kate, back to you.
Thank you very much, Will. We will be back with you shortly. So yes, this evening's clinic is all about bowel cancer, and we're going to start by having a think about, why is this such a hot topic for us working in primary care? We're going to have a little think about risk factors for bowel cancer and perhaps, some of the preventative measures that we could be advising patients to take, especially if they have a positive family history and we're worried about their risk. And then Katie's going to talk a lot about effectively implementing the symptomatic fit within our day-to-day practice in primary care. And of course, that's relevant not just for GPs amongst us, but we have a lot of expertise in the audience from other allied health professionals. And this is relevant to anybody really working in primary care. And finally, we're going to have a look at some of the new developments in the bowel cancer screening programme, which of course is well established within the UK. So Will, as he said, he is going to be answering all your questions, so please do keep him busy. We've only got an hour and there's an awful lot to get through. There are some poll questions as we run through the presentations, and then really that's just to gauge the mood of the audience. So please do get involved in those. Helps me think that I'm not just chatting to myself in my study. And if you haven't already found it, there's a resources tab on your screen as well. And within that, we have put all of the really relevant resources, all the stuff that we're actually presenting this evening, so that if you want to, you can go and have a deeper dive into that at your leisure. Okay, let's get started and let's ask this very simple question. Why are we discussing bowel cancer? Now, bowel cancer, we know, is incredibly common. In fact, it's the fourth most common cancer that we see in the UK, and it accounts for about 11% of all new cancer diagnoses year to year. Now, that equates to over 44,000 new cases each year within the UK, which is about 120 per day. Now, bowel cancer, whilst it might be the fourth most common, is the second most common cause of cancer death, and it accounts for about 10% of cancer deaths year on year. And this is why we're really talking about bowel cancer, because what is shown in all the evidence and what you can see on the graph to your right is that survival is strongly linked to stage at diagnosis. You can diagnose somebody with a stage 1 bowel cancer, then their 5-year survival exceeds 90%. Whereas if they get diagnosed at stage 4, that drops off dramatically down to about 11%. Now, what I think is quite interesting, if you just spend a little bit longer looking at this graph, is that you can see that that actually there is a real drop. There's a real slide in survival from a diagnosis at stage 3 to a diagnosis at stage 4. That drops from about 89% survival at stage 3 down to 44% at stage 4. And what that tells us is that actually there is much to be gained from an earlier diagnosis at any point. And even making that step change from diagnosing somebody at stage 3 point of disease from stage 4, that actually we have a lot to be gained from doing that. Now, obviously, what we'd like to do is move everybody from a stage 4 diagnosis right the way up to a stage 1 or a stage 2 diagnosis. If we could do that, then of course survival would be dramatically better. Here's a little poll question just to get you thinking, and I'll give you 30 seconds to have a think about this question and pop your chosen answer into the Q&A box. So, what is the most common route to a bowel cancer diagnosis for patients in England? And we're talking about patients in England because we've got the best data really for referencing from English data. So, do we think it's via urgent referral? Do we think it's via emergency presentation? Or do we think it's via the bowel cancer screening programme? I'll just give you a few seconds to think a little bit about that. There's always a bit of a lag, so I know everybody is busily putting their responses in, but it takes there's a little bit of a delay before it comes through so that I can see everybody's answered. We have hundreds of people on this call tonight, so I want to give everybody an opportunity to get their thoughts across. Okay, that's amazing. That is proper speedy fingers work. Well done, everyone. Let's have a look and see what people think. Oh, look at that. It's almost a 3-horse race, look. So actually, about 35% think it's via urgent referral. The emergency presentations actually have pipped everyone else at the post with 41%. And actually, almost a quarter of people think it's via the cancer screening programme. Let me show you what the routes to diagnosis data tells us. And this is based on the most recent routes to diagnosis data that we have available to us. This data is actually taken just from England, because unfortunately we haven't got similar data available for Wales and Scotland, and the Northern Ireland data is older than what we have here. What you can see from this is about 37% of patients are diagnosed following an urgent referral. So that's a 2-week referral from primary care. 23% are diagnosed following an emergency presentation. Often you can imagine that being an obstructive presentation perhaps to the emergency departments. Just 10% are diagnosed via the screening programme. So in terms of the response to the poll, then it's those referred urgently that are most common route to diagnosis. Now, just lingering on this slide for a little bit longer, what you can also see from this slide, that a late stage diagnosis is more likely if patients present in as an emergency, and that, of course, is associated with worse outcomes. It's fair to say that even our urgent referral diagnoses, about a fifth of them are also diagnosed at that late stage. So you can see where the challenge lies here, that if we want to try and move the stage of diagnosis to an earlier stage 1 or stage 2 diagnosis, we have to make some changes across the board in all the different symptomatic pathways that exist. Let's just think for a little bit about risk factors for bowel cancer, because like many cancers, there are both modifiable and non-modifiable risk factors present. Thinking about the non-modifiable risk factors for a second, the ones that you're stuck with and there's not much you can do about it, then of course age is a big one. Incidence rises steeply from about the age of 50, with the highest rates of bowel cancer seen in those aged between 85 and 89. Family history plays a big part as well, and not just, and there are a few distinct diagnoses here to be aware of. So familial adenomatous polyposis, or FAP, that's one. We've heard a lot about Lynch syndrome, and I'm going to come back to Lynch syndrome in a few slides' time. That's also known as hereditary non-polyposis colorectal cancer. That's a bit of a mouthful, so Lynch is far easier to get your head around. And family history itself is really important, with more than double the risk if a first-degree relative is affected, and that's in the absence of any of these specific genetic mutations. So we can't do anything about the non-modifiable risk factors, but we can give advice around the modifiable risk factors, bearing in mind that it's thought about 54% of bowel cancers are preventable. And the modifiable risk factors to be aware of are inadequate dietary intake, that makes up almost a third of risk factors, processed meat consumption, having overweight or having obesity, being a smoker or drinking alcohol above the limits recommended by the government, and indeed inadequate physical activity. All of these are modifiable risk factors, lifestyle risk factors, which we can talk to patients about if we're trying to reduce their risk of cancer. There are some comorbidities to be aware of as well. Ulcerative colitis and Crohn's disease, the risk of colorectal cancer is about 70% higher overall. That risk increases with the extent and the duration of the inflammatory bowel disease. Type 2 diabetics are at higher risk, with an increased risk of somewhere between 22 and 30%. And then the presence of adenomas, that also increases your risk of colorectal cancer. About 1% of people who have larger adenomas, they're the adenomas that exceed 20 millimeters in size, or indeed adenomas that show high-grade dysplasia. About 1% of these people develop a bowel cancer within 4 years of having a polypectomy. So they're patients that require ongoing surveillance to try and catch any new changes at an earlier stage. There has been in the past some suggestion that actually the presence of celiac disease can increase your risk of bowel cancer as well, but at present, there is no proven association. So there is some evidence celiac disease might increase your risk of lymphoma or adenocarcinoma of the small bowel, but at present the jury is out. So that's not a proven association we need to worry about. I said I was just going to go back to Lynch syndrome, and I think this is just really interesting because Lynch syndrome has become a hot topic in recent years because it's now being diagnosed much more frequently. Any new case of endometrial cancer or colorectal cancer is tested for the presence of Lynch syndrome changes. And this syndrome is strongly associated with colorectal cancer. It's due to a mutation in mismatched repair genes, and these repair genes, their job is to repair damaged DNA. But when they mutate, they become less effective, and that increases the risk of cancer development. And there are 4 different principal mutations seen in Lynch syndrome, but because there's 4 different mutations, that means that the penetration and the expression of Lynch syndrome is really variable, and therefore patients who have Lynch syndrome can be quite difficult to detect. The important thing to know about Lynch syndrome is autosomal dominant. That means there's a 50% chance of passing it on to your children. and it accounts for somewhere between 1 and 4% of all colorectal cancers. Over 1,000 cases per year are due or are sort of down to the presence of Lynch syndrome. Patients with Lynch syndrome have a lifetime risk of bowel cancer of up to 80%, depending on which of these gene mutations they possess. But at the moment, it's greatly under-recognised. It's thought actually only about 5% of carriers have been identified. The diagnosis is often, or in the past has often been missed, because the cancers develop across different generations within a family. It just means the pattern recognition has sometimes been quite hard. And there's new criteria out there now to help sort of steer this diagnosis and increase the pickup rate. Now, if patients are diagnosed with Lynch syndrome, surveillance screening is highly recommended. And that surveillance screening takes the form of colonoscopy. It's recommended that it should start either at the age of 25 or at the age of 35, depending on which gene mutation is present. And of course, regular colonoscopic surveillance greatly reduces the risk of developing a significant colorectal cancer, but doesn't eliminate it. Now, one of the big changes that we saw last year was that patients with Lynch syndrome had started to be included in the bowel cancer screening program, whereby their automatic invitations for 2-yearly colonoscopy were actually being organised and rolled out by the screening program, which of course is well set up to be able to do that. So that hopefully means that our pickup rate or our surveillance rate for our patients with Lynch syndrome will dramatically improve going forwards. Okay, I'm going to take a pause there. I'm going to hand over to Will so that he can feedback on some of your comments on that first section. Will, what have you got for me? What's the general mood of the audience?
Yeah, mood is positive, Kate. Some great thoughts coming through already. So Artie wants to know about the association between inflammatory bowel disease and the increased risk of cancer. Is it known how much is due to chronic inflammation of the disease process itself, or more due to the treatment, such as immune-modifying therapy? I've just done a quick literature review on this, and it appears to be that it's driven primarily by the chronic inflammation component. But interestingly, it doesn't just, inflammatory bowel disease doesn't appear to just increase the risk of colorectal cancer. It also increases small bowel cancer, intestinal lymphoma, and cholangiocarcinoma. So there's obviously more complex mechanisms going on there. Great question here from Claire, who says, perhaps this is a patient of yours, says if a father has bowel cancer in his 70s, poor lifestyle, alcohol intake is the risk. An alcohol intake, so he's got a couple of risk factors there. Is that risk still, say, double for, I presume, a child or relative? I think it's really hard when we're looking at observational data and extrapolating accurate risk, particularly when you're using that in a real patient setting. You're taking population level data and trying to apply that to an individual. So I think it's very hard to be accurate on our risk prediction. The other point to make is that when someone develops cancer later in life, over the age of 70, and they've got other risk factors for that cancer, it's probably less likely to be a genetic event. So I think there's a lower risk of something like Lynch syndrome in this case. But that's a really interesting thought. Kerry, we're ahead of things here with your question about FIT testing. Do we use FIT tests in frank bleeds such as hemorrhoids? Is there value in using it? And the answer to that is yes. According to the NICE FIT study, there's really good evidence to show it can help to differentiate sinister from benign causes for rectal bleeding. And that is a great moment to bring you in, Katie, because I know there's going to be lots and lots of questions about FIT testing, and that's where you come in. So over to you.
Thanks, Will. That's great. And, I think obviously Kate's made a really good case there for us finding colorectal cancer sooner, and what we're really hoping is that FIT is going to be the tool that's going to help us to do that. So what we're going to do just now is spend a little bit of time thinking about how we use FIT and also maybe what some of the limitations might be of FIT as well, and some questions that we need to ask. So we'll just take a closer look at that. I'm going to ask another quick poll, so we'll put you on the spot again. Threshold of 10 micrograms per gram of hemoglobin. Approximately what proportion of those diagnosed with colorectal cancer will have a FIT negative test? That wording slightly odd, and I'm just thinking about that. So basically, how many people do you think with colorectal cancer have got a negative fit test less than 10? And if you just fill that in, and we'll work in the background and bring that through for us in the results. So I hope everyone's feeling familiar with FIT already anyway, but I think as with a lot of tests, the more we use it, the more questions we have to ask about it as well. So we'll hopefully answer some of those as we go along. Okay, so we've got the results up there, and so the majority of people saying 1 to 5% have got a bit less than 10. It's actually the 5 to 17% with a fit less than 10. But I think, again, we'll come back to this, but the important thing is that doesn't mean that they don't have other symptoms as well. So although they might have a fit of less than 10, they may have other things to find on examination or abnormal blood tests. So we'll pick that up as we go along. Thanks, Will. Right, so what's FIT test and why is it useful? And I think, again, the thing with this is it's nothing magic. It's a test for blood in the poo. It's not a test for cancer, and the test should only be offered to people over 18. But what we do know is that people who are symptomatic with blood in their poo detected by FIT are at higher risk of bowel cancer. And the thresholds that we're using for people with symptoms are of FIT more than 10 microgram per gram of feces is a positive test. In England, Scotland, and Ireland, the threshold is more than 7 micrograms of hemoglobin per gram. Some of that's to do with how the machines work, and that probably will become aligned at some point, but that's the difference at the moment. And we can use the result to tell us about how urgently somebody needs to be referred. So whether it's an urgent colorectal referral, if somebody has a positive FIT test, or it might be an urgent non-colorectal suspected cancer pathway. But equally, we may find that somebody is at lower risk and needs a non-urgent referral, or we might look after them in primary care. So it tells us about how to refer, but it also, the result can be used in secondary care to inform what the first test might be. It's usually colonoscopy. The investigations being used, like CT colonography and colon capsule, and so that sort of stratification to make the best use of the investigation resources that are available is also important. And the reason FIT is useful to us, it goes back to some of the data we've just looked at. That if less than half of our colorectal cancers are detected by a suspected cancer pathway, then the symptoms by themselves aren't helping us to find the right people. And we, even with the change in the NICE guidance in 2015, where the positive predictive value is the lowest threshold for referral is 3%, it actually uses a combination of symptoms and age and investigations to reach that 3% threshold for colorectal cancer. So what FIT can help us to do is to increase the positive predictive value or value of the symptom combinations for colorectal cancer. The negative predictive value overall for colorectal cancer is 98 to 100%. But because of the prevalence of colorectal cancer, that translates back to that, well, we just looked at, that 5 to 17% of people will still have a FIT less than 10, even if they have colorectal cancer. But it's a sense, the FIT test itself has got quite a high level of sensitivity and specificity for colorectal cancer. So if we get these FIT negative colorectal, what does that mean? I think the key message from this is you can't use FIT in isolation. You have to examine your patient, you have to take a history, including your family history. The examination needs to include a PR, and you need to look at blood test results, because we know that a lot of the people with a FIT test less than 10, if they do have a FIT test less than 10, will have something to find on examination, either a rectal or abdominal mass, or that they'll be anemic, will be some other pointer, or they may have weight loss. So FIT less than 10 shouldn't reassure us that no cancer is present. in somebody with ongoing and concerning symptoms, and we should be thinking about other referral routes or using advice and guidance or safety netting. So some of this we'll come back to again. So the other thing on that line as well is that FIT only tells us about the risk of colorectal cancer. So we need to think about, for instance, somebody with weight loss or significant abdominal pain, and we've done a FIT test and it's less than 10. Colorectal cancer isn't the only possibility, and there'll be other cancers that we need to exclude as well. So at the same time, colonoscopy might not be the best first test for that person. So actually we should think about, is there another referral route? And things like the serious non-specific symptom pathways are probably going to be more useful for that person. Another example is a man of 50 and he's got a change in bowel habit, an iron deficiency anemia and a FIT of less than 10, then we might not be referring them for suspected cancer referral for colorectal cancer on a fast track 2-week wait pathway, but that person still needs an upper and lower GI endoscopy, and we would need to do a referral where they would be offered that within 6 weeks. So it's always that question of, I've got the risk result, what does it mean for this patient? Do I need to do anything else? And of course, some people won't need further investigation, but they do need a safety netting advice, which might include planned or patient-initiated review. So this is where the slides get pretty heavy, and I'm not going to go through each of these in absolute detail. You'll have access to the slides and you can look at them in detail. And the reason that they're there is because the guidance is slightly different for England, Wales, Scotland and Northern Ireland. But for England, the NICE guidance has been updated to this DG 56 guidance, which is explicit about the people who we should offer FIT test to. So you'll recognise some of those as being the previous criteria for referral. Now they are the criteria to offer a FIT test. And if the FIT test is positive, we refer on an urgent suspected cancer pathway. And if it's less than 10, we have those questions about, is there somebody else that they need to see? Is it a different suspected cancer pathway? There are some exclusions. So people with a rectal mass, anal mass, or don't need to have a FIT test before referrals considered, and that's mirrored in the other guidance as well. So we'll just skip over some of these. The NICE and BSG guidance relating to FIT is applicable nationally as well. And the Scottish referral guidance, one of the things just to highlight here is that there is a direction to offer a repeat FIT test within 6 weeks if the FIT is less than 10 and there's still ongoing concerns. There are some local variations in England as well about that. So again, make sure you know what your local guidelines are. And then the Northern Ireland guidance, again, just to highlight that difference in the threshold for referral, which is a FIT of more than 7 is a positive test. So this is a summary of the guidance. We mentioned the difference, the threshold for Northern Ireland. In England and Wales, it stratifies guidance by age, and that's not the case in Scotland. And in Northern Ireland, you are advised to use a FIT test for somebody with anal rectal mass, but the test can follow the referral to avoid delays. So we'll just move on from there. So we've decided FIT is a good test. We want to be using it because we think it's going to help us find more cancer. So how do we actually persuade our colleagues that we're going to do that, and our patients? And I think the key things here is to make it attractive, make it easy, and make it safe. And that comes back to our safety netting messages. So making it attractive, I think we've heard the case for it there. So it's we've got clear guidance now from NICE, BSG. They've got the Scottish and Northern Ireland guidance. We're being advised to use FIT to help us with colorectal cancer. In England, we've got the IAF and PCN DES incentives, so aiming to get 80% of suspected colorectal cancer referrals with a FIT test and recorded in the GP notes in the 21 days before referral. And the reason we're wanting to use this is because we're hoping to detect colorectal cancer earlier and get a stage shift. We want to pull more people into managed cancer pathways because we know they generally do better, and we want to reduce emergency presentations when people do worse. So it's about getting people to the right test sooner. We need to make it easy for us to do in practice. So from practical point of view, for a clinician, where are your fit supplies? Where are they kept? Who does the ordering? Are they in date? Does everyone know how to give out the kit? Do you know where the patient information leaflets are? And are you confident the patient is able to do the test? And the patient information leaflet, there's some CR UK resources that are hyperlinked on the bottom there. So you might want to have a look at those. And then the other thing about making it safe. So making it safe for the test. So we need to think about safety netting, and there are templates and coding that we can use in EMIS and System 1. There are some standard AccuRx messages and that can be sent immediately, and then a scheduled message 2 weeks later. Patients to hand their test back in, and sending a test to yourself is often a way to make sure that you then, and there are regular safety net reports that can be run, check has the test been completed, have positive tests been actioned. And one of the things I think for us to think about with the test is how much of it can be automated, so making it less dependent on us as GPs to do something else. So one of the examples of that is having a built-in reminder from the lab. From the patient and GP perspective, and thinking about why the fit test is needed, and being really clear in what we're telling the patients, making the information instructions clear for the patient, thinking about the links on the other slide. Have we got the right language? Have we got the right format for this person to understand the information? And document and discuss the actions that you would want to do if this result is positive or negative. So making that clear in the notes so that anybody else could follow up with that patient. And when you think about safety netting, do you make a planned or a patient-initiated review, and what would be your alternative referral route as well? So, easy things. If the fit is above the threshold, including above 7 in Northern Ireland, discuss suspected cancer referral with the patient and do the referral. If the result is less than 10 or less than 7, don't file the results without checking the patient's notes, and think about what was the indication for the test, what was the plan if the fit was below the threshold. And what might success look like? So I suppose I've only got our own example. So in the Northern Cancer Alliance, for our IF score, we're actually running at 80% now of our low GI referrals have got a fit recorded in the GP notes in the 21 days before referral. 90% return rate, and about 1.5 to 2% that are spoiled or unusable when they get to the lab. And one of the things that's helped us to do that is we've got a fully postal service. The kit is sent out labelled and with the patient information leaflet and the return envelope. And we also have this built-in safety message from the lab to the GP, so that if the lab don't get a result back, don't get a kit back within 14 days, they send us a message on ICE to let us know. So we've got opportunities to chase the patient up at that point. Despite that, we know we've got underlying variation. So looking at requesting rate across GPs, what the return rate, what the IF score is, and also what the screening uptake is, are all things that we would like to still be able to improve on. But some of the data helps us to look at that and target some of that work. And targeting that work, and in terms of addressing inequalities across the system, that we're gathering more information now about the kind of things that are affecting people. So in the CR UK public survey, that most people said that they would do fit test if they were asked to. But the people that were significantly less likely to say yes were men, people in younger age groups, compared to Scotland, socially deprived areas, and people of non-white ethnicity were also less likely to return a fit test. And the top two sort of things that people had said of the test, or perhaps the outcome of the test, and also embarrassment. So if we're going to use and increase detection of bowel cancer in people that at the moment might be less likely to present early, then we have to think about what the challenges are for screening and symptomatic fit. And one of the main things, obviously, is it's a test that relies on being done by the patient. It's not something we are doing to the patient. We are asking them to go away and do this themselves. The test needs to be processed within 14 days. So if it has been hanging around for too long, then it can't be tested. So people need to understand what the test is. They need to remember to do the test. You need a certain amount of physical dexterity to do the test, write the date and the details on the kit. And obviously for people with visual impairment, that's, there's an additional challenge there as well. And you need to remember to actually hand the test back in again. It's going to come back to this in later slides as well. So sort of a bit of a summary really is just to be aware of your existing and updated guidance that might affect your practice. So what's the guidance in your locality? With a fit less than 10, and particularly people who decline a fit, or they find it difficult to do that, consider what the barriers might be that might prevent people completing a fit test and how to reduce those. To make a clinical decision. If we cannot get a fit test, we need to make a clinical decision about referral anyway. We need to be prepared to do that. And think about what you can do locally to make the test attractive, make it easy, and make it safe. So I will stop talking and hand back over to Kate again. We can come back to any of these slides if anybody wants a bit more information. And I know Will's keeping an eye on the questions in the chat.
Thanks very much, Katie. That was a really good rundown of fit testing. It's a very confusing area, certainly not helped by the fact that there are different guidelines in place for different regions in the UK. And most of you in this group are from England. There's a few from Scotland. There's one delegate from Cyprus. But if you're in Wales, Northern Ireland, again, the guidance around this is very different. So you're not alone if you're a bit confused. A few great comments I just wanted to pick up on. In terms of the practicality of taking the test, John is asking, do you take the fit sample from inside the stool or the surface? There is a correct technique for this, and it's really important, as Kate said, to optimize the accuracy of the test and the adherence in doing the test from the patient. We need to deliver clear instructions. They should be scraping the stick along the poo until all grooves are covered. And of the sampling tool, and that goes in the sample pot and off in the post. There's some really good resources. Whenever I request a fit test, I always send a little link to the videos, and there's some infographics on how to correctly do the test, how to actually catch your poo in the first place. We mustn't ignore that, because as we've seen, many patients just don't do this. And that's actually a really important point that was picked up by another delegate who says in their area, I'm just trying to find, yes, Michael, this was something you raised. He said he's had a couple of cases of diagnostic delays as patients just don't send the kits off despite repeated prompting. And that is, that loss to follow-up when you've made the decision to do a fit test and the patient doesn't do the test is a big problem. Ideally have systems in place in your practice to mitigate this through practice reminders, but that is a big problem, and we need to try and plan for that. The other kind of practical request was, do you send the path form with the fit test as well as the documenter? I mean, each locality has its own different kind of sample bottles and processes. The most common one is you request the fit test electronically through System 1, EMIS, whatever you're using. You print off the request label, that goes on the bottle, and then you give that pack to the patient, and they take that sample themselves with clear instructions on how to do it, and they put their sample in the tube, and then they put that in the post. And yeah, there's a lot of steps to go wrong there, so you can see why that loss to follow-up occurs. Okay, just a couple more questions, because there's so much here, so much great stuff. Would FIT test be positive with hemorrhoids, and can you do a FIT test reliably in someone with inflammatory bowel disease? Oh, God, such a meaty one. In theory, yes, you can get, there is evidence to show there is an increased risk of false positives with other causes of bleeding from the lower GI tract, and that includes things like IBD. I couldn't find any good data on how much that interferes with your FIT result, but it certainly is a factor. And the final question, because I know we've still got lots to go through, is this idea, and who was it that raised this? I'm just finding it now. Yes, Hannah, you were asking about some patients who've been discharged. So there was clinical concern. They had symptoms of potential cancer. They had lower FIT. So they were younger women in their 40s. They had a FIT result of 8. And they were discharged and then went on to have a diagnosis of cancer. And this is a really key point to hammer home, is that a negative FIT result, so below 10 in the diagnostic threshold that we use in England, is not no risk, it's low risk of cancer, and there's a false negative rate of 8%. So if you have ongoing clinical concern, and even though the FIT test is technically negative, still consider further investigation and onward referral. Great stuff. Keep them coming. Love the energy. Kate, over to you.
Thank you very much, Will. I can see you are incredibly busy, so that is awesome. That means that there are lots and lots of interested parties, which is fab. Katie, so we set the scene a little bit in the first part. Katie has painted a really compelling picture as to why it's so important that we have the modality that is symptomatic FIT testing to help sort of inform our referral pathways. We're going to finish this evening now thinking a little bit about the bowel cancer screening programme, which is another really important bit of the jigsaw. And we're going to talk, first do a poll. So Katie and Will have both sort of reiterated that point that for a symptomatic FIT, for a FIT test done in somebody with symptoms that you are concerned may be related to a bowel cancer, we've talked about a threshold of greater than 10 for being abnormal, or greater than 7 in Northern Ireland. This is a different question now. So the threshold for a positive FIT in the bowel cancer screening programme is higher than with a symptomatic FIT, much lower than with a symptomatic FIT, or the same as with a symptomatic FIT. So it's higher, lower, same. What do you think the answer to that might be? And you will be pleased to know that this is the last poll question, so you can literally turn off the grey cells after this and just sit back, relax, and enjoy the next 15 minutes of CPD updates from this clinic. Okay, let's have a little look and see what the general votes are. All right, so majority, almost 60%, think that it's much higher than the cutoff for a symptomatic FIT. There's about a fifth, though, that think it's lower, and then again a fifth that think it might be the same. So let me try and illustrate the differences here, looking at this quite useful summary slide. So this is our bowel cancer screening programme at a glance, and you can see that that there are lots of similarities across the devolved nations of the UK, and there are some key differences as well. So all 4 nations use FIT now as their test, their screening test. Used to be, of course, the GUAC fecal occult blood tests, but fortunately they've now been replaced by FIT. But you can see that the age ranges vary from country to country, and this actually I can update you a bit more on age ranges in just a second. You can see that everywhere it goes for a 2-yearly screening option, and then here are the thresholds that we're talking about. So in Scotland, the threshold for an abnormal screening test is set at 80. And in the rest of the UK, it's set at 120. So much, much higher than for a symptomatic fit test, where the threshold for a positive test is either 10 or 7 in Northern Ireland. So if you look at the National Screening Committee and their recommendations as to what the bowel cancer screening programme ideally would look like, they would recommend that a biennial, so twice yearly, every 2 years, a fit screen is carried out for everybody aged between 50 and 74, with a threshold for a positive test set as low as possible, down to, the screening committee recommend, as low as a threshold of 20. And actually, if you look across other sort of Western countries at what their screening programs are set up like, and actually other countries are already using thresholds of somewhere between 20 and 45. Now, the reason that we are not doing that in the UK at the moment is because we don't have capacity within our endoscopy services or our pathology, our path labs, for processing all of these screening tests. So at the moment, capacity would far outstrip supply, and therefore we have to be a little bit more moderate in our approach. That said, both England and Wales are striving to get down to that starting age of 50. And as recently as December just gone, so December 23, within NHS England announced that they were going to start to invite 54-year-olds to the bowel cancer screening programme. So it's edging down ever closer to that threshold of 50, which of course is where Scotland is already at. And as capacity expands, so within England, that starting age will come down. Wales is doing something very similar. They were at 60 years old. They dropped it down to 55. And actually from October of last year, they dropped it down to 51. And again, this is all about capacity to be able to process results and subsequently follow up those with an abnormal screen. In addition to that, and I've talked about this once already this evening, we have that cohort of patients that are known to have Lynch syndrome, and they are also invited on a 2-yearly basis, but direct to colonoscopy to make sure that there is no sign of trouble. So I said already that we've moved from using the old-fashioned guaiac fecal occult blood testing to now using FIT, or fecal immunochemical testing. And that has been very well received by patients and by clinicians alike. So it's, as a test, it's far more acceptable to patients. It's much easier to do because there's only one poo sample required for each screening test. And the bottles or the specimen pots that are making it much easier to actually physically collect that stool sample. So as a consequence of it being a better test or a more acceptable test for patients, the good news is that we've seen coverage of the bowel cancer screening go up since the FIT testing was introduced. And these are just, I won't read out the slide, but you can see that there's been a good sort of step change in the right direction across all 4 of the devolved nations in the UK. But of course, there is still regional variation, and Katie's already talked about inequalities in sort of completion of symptomatic FIT testing, and unfortunately, we see a similar pattern for those who are invited to take part in bowel cancer screening. So what's our role in this? Because of course, we see patients, for lots of other things. So what really is the key message for us working within primary care and seeing our patients on a day-to-day basis? And really our role is to promote informed participation in the bowel cancer screening programme. So really, in an ideal world, that would be to proactively discuss the benefits and harms of bowel cancer screening to patients so that they can make their own personal informed decision as to whether or not to participate. Now, benefits, of course, are quite easy to sell, aren't they? That's the opportunity to pick up bowel cancer at a much earlier stage, which would lead to improved survival further down the line. But we do have to be aware of the harms of screening as well, because unfortunately no test is a perfect test and harms do exist. So the harms from bowel cancer screening include false positive results. So those are results where patients are picked up as having an abnormal screen, and they go on to have subsequent investigations for that, which more than likely is going to involve some form of endoscopy. And of course, endoscopy is not a risk-free procedure. There is the risk of overdiagnosis. So that's the possibility that actually patients might be diagnosed and treated for bowel growths that would never cause them any significant harm. And then, of course, there's the risk of a false negative, because this is a screening program in an asymptomatic population, and false negative results do of course occur. But that leads to an over-reassurance, most often by patients, but also by clinicians as well, that if their bowel cancer screening test is negative, they can't possibly have bowel cancer when they develop those symptoms. And that's really one of the key points that's important to understand and explain to patients, is that if they develop symptoms that might be related to a bowel cancer, they must have a symptomatic FIT test, because they are far more sensitive, with a much lower threshold for a positive result. So those are the kind of key messages that we need to understand to be able to relay to patients. And of course, there are lots of other ways that we can do that. So there is lots of material out there to help support these conversations with your patients, explaining what the test is for, how to do it, those harms and benefits. And you can send letters, you can send text messages, you can make phone calls to try and encourage patients to really participate in the programme. And there are lots of different resources available out there. We've put a lot of them into the resources tab for you. And I often say to when I'm talking about sort of informed participation, it's really important to think about sort of communicating in a variety of different modalities. And I'm frequently surprised at how many patients we have that don't have good reading literacy. But actually, if you start applying them with lots of written information, they're not going to be able to participate, because they won't understand what you're giving them. So there are videos, there are pictorial sort of explanatory resources out there. It's well worth just having a supply of different things to be able to use with patients. And of course, it's not just down to the clinician that sat with a patient at any one time. All of our practice staff can get involved in this. So, this goes right from receptionists making phone calls through to our HCAs who are taking blood tests. Anybody who has contact with patients can actually start to have these informed decisions. And that in some way helps to break down these barriers that we're so aware exist. Of course, we've got our, if you're working within England, we've got our early diagnosis DES, and that has really tried to drive innovation when it comes to increasing screening uptake with really defined parameters, or trying to come up with different ways of following up those non-responders. And one of the requirements of the DES is to include at least one specific action to help engage with patients that might be in a group that is less likely to participate. And which are these groups? These groups look very similar to the ones Katie talked about in terms of the types of people that are less likely to bring back a symptomatic FIT test. But it's the same groups of patients, or similar groups of patients, and this isn't an exhaustive list, who are less likely to participate in the screening programme. So patients from non-white ethnic minority communities, men, patients who don't have English as their first language, patients with learning or physical disabilities, any sensory impairment or severe mental illness, and those that are just invited for the first time, especially those younger patients. Now that our age threshold is dropping, if they're invited for the first time, they may feel that it doesn't really apply to them. So looking at this in the round, we've of course got the lack of awareness and lack of knowledge about what the screening programme entails and its benefits. That's certainly one barrier to break down. I've talked already about language or literacy challenges. Some people are really embarrassed talking about poo. I spend a lot of time talking about poo with patients, but some patients just aren't very comfortable talking about stool and how to collect a stool sample. So really trying to break down that embarrassment and sort of trying to reduce that screening anxiety that might exist. There are cultural and religious beliefs to contend with. And then, of course, they've got these, we're talking about an asymptomatic group of patients here. And many patients actually believe that unless they've got symptoms, none of this really applies to them. So we can use IT searches within our practice to identify groups who might be less likely to participate, especially focusing on those that have previously not taken up the opportunity to do a bowel screen, or those that haven't yet responded to an invite that's gone out more recently. Think about those age groups as they get younger. People might not be aware that they are now eligible for a bowel screen. And of course, those groups of patients that we know are less likely to participate. And it might be that a practice protocol or a practice policy needs to be developed to really sort of help your other members of staff talk to patients about this. And if you've got somebody that that needs some additional support in order to make that informed decision, then it's well worth reaching out to your local screening hub who may be able to help further. If you do have someone come back and you're notified that their bowel screening was positive, then of course, making contact with that patient to encourage them to go to their inevitable hospital appointment and to attend for that colonoscopy, explaining a little bit about what to expect, what it involves, and answering any questions they may have. The resources tab, as I've said already, has got lots of information in there. So I would just sort of, once this is finished, its live version, you can go back into that resources tab and you can download anything that you think might be useful for you to take back to your practices. So wrapping all this up for the last two slides, we'll then hand back to Will for a quick wrap up, and before we sort of do a victory lap and go off to enjoy the rest of our evening. Bowel cancer is the fourth most common cancer in the UK. 54% of cases are considered preventable, and there is this large difference in survival if you look at patients diagnosed at stage 1 compared to stage 4, which is why there is this real drive to improve earlier diagnosis. FIT is a really useful decision aid to guide referral in those symptomatic patients who you suspect may have bowel cancer. It is not a perfect test. Unfortunately, no test is ever perfect. So it is part of your armory of investigative tools that you can use when you are considering what to do with a patient. So just remember it's there and use it at will to try and improve this pickup, this earlier diagnosis of bowel cancer. And of course, remember the importance of active safety netting, the importance of making sure symptomatic patients still come back for follow-up if they've got ongoing concerns, because you don't want them to slip through the net. Thinking about the bowel cancer screening program for a second, and the good news is that the starting age is coming down. We've seen that in both England and Wales in the last 6 months. And the threshold for a positive test is also reducing. And it's great that Wales and Northern Ireland have got that down to 120. So we're just all now sort of focusing on getting down to the heady heights of Scotland, where they're down to 80 already. Lynch syndrome, massive, it's one of the big sort of risk factors for bowel cancer. And these patients are now included in the bowel cancer screening program as well, reflecting that really high lifetime risk of bowel cancer, up to about 80%. So those patients have 2 yearly screening with colonoscopies. And of course, our role in this is to support informed participation in the screening program and to really proactively follow up those patients that aren't participating. And hopefully all the resources in the tab will help you do that. Will, I'm going to pause for breath now, hand over to you to do a summary of everything that you've been up to in the last 60 minutes before I sign us off for the evening.
Well, I'm mindful of time, Kate, and I'm just going to pick up 3 key points from our delegates here that I think are worth noting. Caroline's asking, are screening FIT tests less sensitive than ones requested by general practice? And this is a really key point. The screening threshold, the test we use in England is 120. The diagnostic test, the threshold is 10. So yes, that is the answer. Screening fit test is less sensitive. And the key learning is don't be falsely reassured if that patient's had recent negative screening result. Still do a diagnostic test in primary care to provide adequate reassurance. Second point, which I think is quite interesting, Friedrich from Germany says that bowel cancer screening through annual fit test is being offered from the age of 50. And I mean, this is apparently the direction of travel in the NHS. We were offering from the age of 60, and then as of December, from the age of 54. And the goal in the NHS in England is to offer screening with fit testing for bowel cancer from the age of 50 in the future. But unfortunately, capacity has been the main barrier to actually implementing that. And then the final point I wanted to pick up, and a lot of delegates have mentioned this, and actually, Kate, I'm going to hand to you in a moment just to add any extra points on this. Loads of questions around fit testing and rectal bleeding and hemorrhoids and how that all works. Because this is a step change. Before we were told you don't do fit testing if there's bleeding, but now the NICE Fit study has kind of contradicted that received wisdom. I'll explain my understanding of this. If it's bond or hemorrhoidal bleeding, there's no other risk factors. You're confident this is hemorrhoids, then you don't need to do a fit test. You make that working clinical diagnosis. If they've got hemorrhoidal bleeding plus a few other dodgy symptoms, or it's just they're not quite fitting the pattern, then yes, you can do a fit test. Fit test, there are increased risk of false positive results with hemorrhoidal bleeding, but actually those false positives are quite small. And the big win is that the rule out, the negative predictive value of doing a fit test, even if they've got hemorrhoidal bleeding, is still very high. So if it comes back negative, which it probably will, that's very reassuring, and it may then prevent you from doing say sigmoidoscopy, colonoscopy referral, and you've saved the patient a great deal of hassle. That's my understanding of fit test and hemorrhoidal bleeding. Kate, is that a fair understanding, or anything you wanted to add to that?
Thanks. Well, yeah, that's a pretty good summary of the situation. I guess my take is you can do a fit test in somebody with intermittent fresh rectal bleeding that you suspect is likely to be hemorrhoidal. If you're going to do it, then you have to give the patient quite clear instruction on when you would like them to take that sample. So I tend to say to patients, especially if it's intermittent rectal bleeding, don't take the sample from a poo where you've clearly had a hemorrhoidal or you've clearly had some fresh rectal bleeding. Try and pick a stool that's not covered in fresh red blood. If they're concerned that if you sample the outside of a stool covered in fresh red blood, it will be positive. So then what you want is a sample from the centre of a stool. This is why I end up talking about poos all the time, because I talk about sort of almost, it's a bit late for this now, isn't it? Breaking open a stool to take a sample from the inside of that stool so that you are trying to reduce that risk of a false positive result. But you're right, Will, if it comes back and it's negative in the context of fresh rectal bleeding, then actually that patient more likely needs a flexible sigmoidoscopy than they do an urgent 2-week referral for a colonoscopy. So it does change your pathway and your decision-making process. That's probably all we've got time for tonight. We could talk about this an awful lot, but I think we should call it quits now. We're 3 minutes over, for which I make no apology at all. But thank you very much, Will, for fielding all those questions. Thanks to Katie for doing such a brilliant job talking about symptomatic fit and the guidelines and really how we can tackle that within primary care. And thanks to everybody that has been with us for the last hour. It's been super interactive, which is always a lot of fun. The next clinic that we're doing in February is a cardiology clinic, so please do come and join us for that. We won't be talking about any cancer at all in that clinic. That's all brought to you with NB and the Primary Care Cardiovascular Society. So with any luck, we will hopefully see all of you on that free hour of CPD in February. As soon as this webinar finishes, there will be a quick feedback survey for which we'd be very grateful if you could spend 2 minutes answering the questions. That just helps us refine our content for next time. All that's left for me to say is thank you so much for joining us this evening. I hope you found it useful, and I hope you're going to take away some of the learning points back to your practice tomorrow. Look forward to seeing you again soon and enjoy the rest of your evening. Bye for now.